So we do have some slides. Good morning, my name is Emilie Johnson, and this is Courtney Finlayson. And this was designed as a panel discussion, but I think we are leading/are the panel. So we have a few slides, and we're hoping for discussion. I was expecting to have to ask everybody to come to the front because I was thinking we would have a small group, but I'm really excited to see that the room is relatively full, so we don't have to ask for that. Before we get started with the slides, I would love to just know a little bit more about the audience so we make sure to tailor the discussion appropriately. You can't hear me, I'm sorry. Can you hear me now? I was just saying that I'd love to hear a little bit more about the audience. So if you have attended any of the smaller group sessions related to this topic in years past, if you could please raise your hand. So maybe like a quarter. If you care for pediatric patients relatively exclusively, please raise your hand. Or if you work at a children's hospital. And if you are a endocrinologist, raise your hand. Just a few. All right, oncologist. Okay. Urologist. Couple. Gynecologist. Okay. And if you care mostly for adults, I guess that's the other half. Okay. And if you would consider yourself a researcher. Okay. I think that's a pretty good sense for, most importantly, if you care for children or adults with differences of sex development routinely in your practice. So that's a little bit smaller group. Okay, sort of. We've got some maybes. Okay, so this is designed to be somewhat informal, although I know it's a big group, I know it's a big room, so it's hard to be informal in this setting, but please feel free to raise your hand, come to the microphone, and share your experiences. I'm gonna go through a little bit about just an introduction to fertility preservation in DSD, and a little bit about what DSD is, just to make sure that we're all on the same page. We will talk a bit about our approach to offering fertility preservation here, and a bit about the development of our IRB protocol, of which I have copies if people are interested, and then go through some cases. And we have time sort of built in for discussion, so we'll pause many times along the way. Disorders or differences of sex development, also known as DSD, are congenital conditions in which development of chromosomal, gonadal, or anatomic sex is atypical. So that's a really wide definition of a group of conditions that used to be known as intersex and still is known as intersex to a certain extent, although in 2006 this consensus statement sort of expanded that definition to include other conditions which were not traditionally thought of under the umbrella of intersex. And there's a bunch of other terms that you might hear to describe this group of individuals, which can be confusing. So some other things that you'll hear are differences in disorders being used interchangeably, CARD or congenital conditions affecting reproductive development, and many more. And this is a really wide range of conditions, many of which affect future fertility potential for a variety of reasons. So many individuals with DSD are at risk for impaired fertility. A lot of them have abnormal gonadal development, and we'll go through some of the conditions where that's more likely. And along with that, abnormal hormone production and action. Some individuals have anatomic barriers to fertility, for example, women who are born with Myra-Kotansky-Kuster-Hauser syndrome. And then the traditional recommendation for many of the patients with differences of sex development has been a gonadectomy at some point during their childhood. Due to risk of tumor formation in the abnormal gonads. So the idea of fertility preservation, or a few years ago we talked about cryopotential here at this meeting, meaning that a lot of these individuals may be eligible for experimental fertility preservation, but there is a lot of questions about whether that tissue will be able to be used in the future. So we don't want to oversell this concept, but we want to be honest. And so many of our patients, including a lot of those with 46XY DSDs, could potentially benefit from fertility preservation. So one example is androgen insensitivity syndrome, where an individual is born with XY chromosomes, but their genitalia looks typically female or looks somewhere in between because they don't respond to the androgen at all, or they may respond incompletely to androgen. Another example is mixed gonadal dysgenesis. So that's a condition where individuals have a mixed karyotype, so 46X, with 45XO, and their genitalia, again, appear somewhat in between. Often those patients at some point have a gonadectomy, and that tissue may be eligible for, or that patient may be eligible to save that tissue for fertility preservation. Sort of along those same lines, the individuals who are born looking typically female, but for some reason have a karyotype checked, and again have that XYXO karyotype, are one type of Turner mosaic patient who could be eligible. And then ovotesticular DSD. This is a condition that used to be known as true hermaphrodite, but that terminology is really out of favor. But those are individuals who are born with both ovarian and testicular tissue in their body, with some in various different combinations. And those patients also may be eligible for saving that tissue in hopes of having a child in the future. So work from our group has showed that impaired fertility is of an important concern for these families. When a baby is born and they're diagnosed with one of these conditions, often after reassurance that their baby is healthy in general and doing well, one of the first concerns that families come to us with is, will my child be able to have a child in the future? And at first when I started to get this question, that seemed strange to me, that you have a baby who's 1 day old or 2 days old and that's what the parents are thinking about, but that's what the parents are thinking about. And it's a concern that might be alleviated for a while, but it tends to come up over and over again throughout our consultations and visits with these families. So it is definitely an important concern, and we've noted that it's a concern at the time of diagnosis and then throughout the continuum of care. Additionally, work from our group has noted that if you look at the gonadectomy or gonadal biopsy specimens from many of these patients, there are germ cells present. They may not be totally normal germ cells. We are not sure of the potential of all of these germ cells, but the traditional sort of teaching is that many of these patients are infertile. You shouldn't worry about this and just sort of accept that and move on. And looking retrospectively, it appears that more of these patients may have fertility potential than previously thought. However, our preliminary data indicates that fertility potential may decrease over time, at least for some conditions. So that's sort of a nuance that needs to be taken into account with some of these patients. So, as mentioned in the introduction, in the Gender and Sex Development Program here at Lurie, we care for two populations of patients. Although it's all under the same umbrella, we care for kids who are gender nonconforming or transgender, as well as those who have a DSD. And although this session focuses on individuals with DSD, we found that there's a lot of interplay and benefit from caring for patients from both groups. And interestingly, even when thinking about fertility and fertility preservation, the concept of gender identity and gender dysphoria and how that affects thoughts about future fertility does enter our conversations. And the fact that many of our clinicians care for both the transgender folks and the kids with DSD has been really useful in navigating those difficult conversations. So this is our team. Pediatric urology and endocrinology are represented here today, but we also have genetic counseling. We have a fertility preservation specialist who participates in our program, psychologists, social work, nursing, and pediatric surgery, who all care for these patients together. And it really is considered the standard of care at this point for kids with DSD to be cared for within this multidisciplinary setting. I think we've found, particularly when talking about any surgical issue, having the input of all of these specialists is incredibly important. I don't know how many of you are aware of a lot of the controversies going on in our field right now, but there are a lot related to timing of surgery, whether any surgery should be performed at all, who should be involved with the decision making, et cetera. And anything to do with fertility preservation requires a surgical procedure, the talk about gonadectomy, et cetera. So caring for these individuals within this context is particularly crucial, especially given current events. So gonad management is changing for individuals with DSD. As I mentioned before, infertility used to be just assumed, and cancer risk was thought to be high, and so early gonadectomy was recommended for any patient where we thought they sort of fit that picture. But in the evolving paradigm, things have become a little bit more complicated. So our knowledge about fertility potential, or about possible fertility potential, is expanding every day. And cancer assessment risk is much more individualized now. So just because you have a DSD with a risk of cancer that's higher than the general population doesn't mean that that risk is 50%. It might be 2%. For one patient, it might be 50% for another. And so providing that counseling about everything we know about that individual's risk is really crucial. And therefore, any decisions or any discussions we have about gonadectomy are made with a multidisciplinary evaluation, shared decision-making, and with the patient input whenever possible. So in the past, a lot of gonadectomies used to be done for infant patients, and at least here at Lurie, things are changing, and these conversations are really challenging. And adding in the conversation about fertility, possible fertility preservation and fertility potential does complicate things, but I think it really also benefits our patients. So just a very brief overview. In general, a patient comes to our clinic, they receive some sort of diagnosis where we think that their gonadal function might be compromised and that their tumor risk might be elevated. And so with all of the specialists, or many of the specialists that I showed on the prior slide, there's multiple visits. It is very rare for us to have a patient see us one time and decide to have a gonadectomy. So after sort of a careful consideration of all of those options, then sometimes families do make the decision for gonadectomy, whether that be earlier in infancy or toddlerhood or later in adolescence or young adulthood. And although the discussion about possible fertility preservation does happen to a certain extent when making the decision about gonadectomy, really, in the end, the decision about that surgery and the decision about whether to save the tissue are sort of cognitively two separate decisions. And so if the family, after making a decision about surgery, thinks that they may want to pursue preservation of that gonadal tissue, then the details are discussed with more specificity, including a separate fertility preservation consult. So not necessarily all of our patients meet with a fertility specialist, but many of them do. That doesn't mean they ultimately decide to save tissue, but that is something that we offer for our patients if the families are interested. And then after that more comprehensive assessment and counseling, the family and patient make a decision about whether to attempt fertility preservation. So just to present a couple of sort of the different scenarios with the young child versus the older adolescent young adult. So the younger child who really can't participate in the decision about fertility preservation or gonadectomy, this conversation is really happening with the parents. They're counseled about the pros and cons of gonadectomy, and then if they elect the gonadectomy, the experimental tissue preservation could occur. And the types of conditions where this is really most relevant, I have on the slide complete androgen insensitivity, but I would say that for those patients, again, these are patients born looking typically female on the outside, but who have XY chromosomes, who don't respond to androgen. Those patients, their tumor risk is actually thought to be quite low. And so there's been a shift away from gonadectomy for some of the younger patients, but occasionally that comes up. A partial androgen insensitivity, where there's some response to androgen, the risk of tumor is higher. And so there's more conversations at a younger age about whether gonadectomy is appropriate. Mixed gonadal dysgenesis, as I mentioned, or the Turner mosaic patients that I mentioned in the previous slide, those individuals with the XY-XO karyotype do have a higher risk of malignancy. And so we at least talk about whether families want to pursue the gonadectomy, and if they do, possible fertility preservation. The discussion becomes a little bit more complicated, mostly in a good way, I think, when the patient is able to participate. And in this situation, there may be malignancy risk, there may be some element of gonadal failure. The patient, for various reasons, may be considering starting hormonal therapy. And at that point, often we will assess the presence and degree of their fertility potential and then consider fertility preservation before gonadal failure. They're having gonadectomy, one side, both sides. There's sort of a lot of different clinical nuances that can occur, but these conversations tend to be more complicated. And some of these, at least in the future, may be a biopsy in fertility preservation rather than a gonadectomy, although we have not pursued that yet here. And I can talk more about that when we discuss the protocol development. So there's some issues. There's a lot of issues thinking about fertility preservation or preservation of fertility potential in DSD. For all patients, and this is not unique to DSD, but cost is an issue. I think cost in some ways is more of an issue for this group of patients because There's so much that is unknown. Their inherent gonadal potential is not normal in general, and so we are particularly sensitive to the cost issues, especially for families where this is a stretch, because we can't promise that this tissue will be usable. Some of these patients are prepubertal, some aren't, but even if they're peri or postpubertal, the tissue may still not be typical and may never be able to be used. So we're very honest about that, and it's important that the families understand that. As I mentioned, the presence or quality of germ cells may be unknown, although for the teenagers we try to assess fertility potential. Often we're going into the operating room saying, we're going to do the gonadectomy for a clinically indicated purpose. We will evaluate the tissue under the microscope, and we won't necessarily know if fertility preservation is definitely possible or preservation of fertility potential is possible until several days after the procedure. And that's sort of a hard unknown to discuss with the families. And then, again, not unique to DSD conditions, but perhaps more common is the concerns about transmission of a genetic condition to offspring if the tissue were to be used in the future. So it's just another issue that we have to discuss with the family, talk about pre-implantation genetic diagnosis, et cetera. And then some more issues with the adolescents and young adults. So a challenging situation is that the adolescent and young adult and the parent may not agree on fertility preservation. We've seen this more in our trans population, but this in theory could happen with the individual with DSD as well. There's definitely psychosocial implications of a new versus an established DSD diagnosis. We find, the adolescents are at very different phases if they just found out that they have a difference in how their body developed compared with if they sort of grew up knowing. And as I mentioned before, we care for both trans kids and DSD kids in our program, and just because you have a DSD doesn't mean that you are also not trans. And so the kind of integrating in gender dysphoria, talking about the idea that the cells that you preserve may not match the patient's gender identity. All of those issues are complicated, and you have to think about how to be able to communicate those to an adolescent and their family. So the logistics. In general, the fertility consultation occurs in the DSD clinic, occasionally in our separate Lurie fertility clinic, and sometimes over the phone, especially if we've had a lot of the preliminary discussions in our DSD clinic without the fertility preservation team being there. We definitely talk about the experimental nature of the tissue cryopreservation and how that's even more experimental than in the cancer population. We talk about cost and storage logistics. There are some scheduling constraints about when surgeries can occur, which is just sort of a practical issue. I'm happy to go into more detail about that if that would be useful. We review our study protocol. Again, I'll go into more detail about that later. And then the consents for the experimental portion of things is signed on the day of surgery by both parents. So the IRB protocol requires both parents to consent, an assent from the individual if they're 12 or older. So I'll stop there. That's enough talking. And love to open it up for others who maybe are offering this service or thinking about offering this service, comments or questions about what I've gone over so far.
Thank you. That was a really wonderful presentation. Could you describe your monitoring of patients when you're managing them conservatively, particularly for gonadal dysgenesis?
It's a great question. I don't know if you want to take this one. Or you want me to? Go ahead. Okay. I'll start. She may piggyback on what I say. So, like every bit of DSD care, it's definitely individualized. There are no established protocols for DSD in general or by condition. If we can see the gonads on ultrasound, that's helpful. And so we typically will do an ultrasound every 6 to 12 months for families who elect not to pursue gonadectomy. However, there is definitely data that exists that shows you can have malignancy in a gonad that does not show an abnormality on ultrasound. So I think it's, from a cost standpoint and a logistical standpoint, unrealistic to do MRIs every 6 to 12 months. But I know that for certain condition that's been at least studied. But we tend to do ultrasound knowing that we might be missing something.
It was perhaps a bit of a follow-up, a similar question. So what numbers do you give these patients when you say it's not a big risk? The patients can say, well, what risk is it?
As far as malignancy risk?
Yeah. Particularly, I'm thinking particularly of the more complete androgen sensitivity is a case in mind.
So I think we base it on the limited literature that is available. And, for a patient with complete androgen insensitivity, we would typically say, well, the data that's out there says the risk might be anywhere from 2 to 12% of developing a malignancy. Typically that's, there may be tumors that are present like gonadoblastoma that have potential for malignant transformation. Typically that wouldn't happen until the second decade of life or older, but it could happen at any time. And there are a few rare reports of this happening, under the age of 10. And so usually we give, so that might be the statistics we might give for something like complete AIS, whereas for, partial androgen insensitivity or gonadal dysgenesis with intra-abdominal gonads, we would say, the risk is reported as more like 40 to 50%, but whether that's something that's going to happen when you're 12 or when you're 35 or when you're 50, there is no data to give us that information. And so we typically present all of this to the family, and then we'll say, everybody's assessment and tolerance of risk is different. And so for some families, and I think anecdotally, this seems to be a little bit more, well, sometimes it has been particularly with families where they have had, the parents had difficulties with fertility on their own. I feel like the parents have had more tolerance for the risk and said, no, we want to keep the gonads in as long as possible. Whereas other parents will say, I can't sleep at night if I'm worried that my child is going to develop a gonadal malignancy. And so I think we've seen very, very different responses from families.
Thank you. Can I ask a slightly different second question about when you're offering cryopreservation for these gonads, you don't really know what you're going to get. I'm just thinking that the sort of laboratory backup for that is going to be very different if you've got immature testicular tissue versus potentially some more mature sperm forms present. And I know there's a lot of debate in the literature how best to do this, what the appropriate media to store the tissue in. How do you account for all those uncertainties when you don't know what you're going to be getting?
That's a great question. I am certainly not an expert. I don't know if Monica Laranda's here. She might also be able to.
Yeah, Kyle. Maybe Kyle can speak to the fact that what can you do with these immature? Because my question is, leaving the gonads in, they're not going to get pregnant the normal way anyway.
Some have, though.
Some have? I'm curious about that.
So there are like 2 reports of individuals with ovotesticular DSD having spontaneous pregnancies. There are a couple reports of XOXY, Turner syndrome girls having spontaneous pregnancies in adulthood. So it is possible.
Okay, that's good information. Thank you.
And right
I'll speak to Professor Orwig later, perhaps.
Yeah.
Well,
I mean, the testicular tissue is processed via their method.
So there were actually kind of a lot of questions there. And in our place, in the same fertility preservation program, we process testicular and ovarian tissue, so we would be prepared for whatever we receive. The issue about whether it's an immature tissue or whether there might be sperm in a testicular tissue does impact the way that we process. So if we perceive that there could be sperm there, we would process the tissue like a TESI sample, which basically means tease the tubules apart and see if sperm swim out. If so, we would preserve those the way that you would for any testicular sperm extraction procedure, and then we process the rest of the tissue for tissue-based or cell-based therapies that might be available downstream. So we kind of take care of everything because we can't anticipate for sure what might be available in the future.
No. I'm just going to try to summarize, and then maybe you can tell me if I said anything wrong, just so the crew on the other end can hear. So the summary was that if there's any possibility of mature sperm, then the sample is processed as if it was a TESI specimen, so that the sperm would be teased out, saved separately, and then the whole tissue cryopreserved in a different method. One, again, sort of logistical comment is that we used to actually send our testicular, well, we do send some of our testicular tissue to Kyle's lab, but for these patients, we keep all of our specimens or all of our samples in-house, and they now go to the Laranda lab because we don't know what we're going to get. And actually, we just had our first example, which we'll go over later, of one where we had both. So we don't know ahead of time exactly what type of tissue we're going to have.
Yeah, so when we actually get a dysgenic gonad, it's hard to determine exactly what it is, and there's clearly no mature sperm or anything like that in there. We process all the way through, and instead of coring out a medulla like you would for ovarian tissue cryo, we process and save the entire thing. So that is just like a slightly different protocol than what's done for an ovary or a testis, just because we just want to be careful and save everything.
Hi, I'm Rocha, third-year fellow from Einstein. I had a question. If you have patients specifically with something like a Turner mosaic, is there any role in AMH levels or monitoring AMH throughout time, and does that play a part in determining timing of fertility preservation?
So we measure AMH levels, and I think we're not quite sure how to interpret them, but it may have some impact, but there's no clear, good data to really tell us what that means. I know there are some, there is a Turner syndrome protocol that's out there about fertility preservation in which they measure AMH levels, and then once the AMH level drops below 2, then they recommend fertility preservation, or would potentially do ovarian cryopreservation. But I don't think that's really based on any clear data.
Sorry, I'm just fascinated by this.
Yay!
Just so many questions. Sorry, this will be my last one, but I will come and talk to you afterwards. For the dysgenetic gonads, do you counsel the patients that the tissue shouldn't go back inside for autografting, or do you, like for example, do you rely on in vitro maturation, and what's your discussion with the families?
I think we have presumed that, yes, it would have to be in vitro maturation and that you would likely not want to implant this tissue. However, none of the patients have actually asked us about that. But yes, that is what we have thought would be, that is sort of how we have presented the information. Although I do wonder if at some point you could temporarily reimplant the tissue and then remove it again. But I think we haven't even been close to getting to that point, so we haven't had a lot of discussion.
I don't know if you're going to present the numbers of patients. Are you going to talk about that in your experience?
Yes, we'll talk
Okay,
some more
great.
about our
That would be
experience.
helpful.
You want to keep going?
Yeah, I'll keep going, and I just want to talk a little bit about. I'm going to talk a little bit more about the development of our protocol, which I refresh my memory on, was definitely a labor of love and continues to be. It took us like 5 days shy of a year from the time that we first submitted the protocol for it to be approved, and I've tried to summarize the lessons learned in like a couple of slides, but again, this is a topic that we're happy to share as much as we can about, because it certainly was a process and a labor of love, and hopefully we can save people some time and improve efficiency as life goes forward. So we kind of felt like we didn't have a good fit our previous approach was to have the patients who potentially would be eligible for fertility preservation to be a planned exception to the oncology IRB protocol. And over time, we learned for so many reasons that was a bad idea. The language in the IRB didn't make any sense. Right as it stood, we had separate protocols for ovarian tissue cryopreservation and testicular tissue cryopreservation, which is not relevant for some of our patients. There was a lot of scary cancer-specific language in the oncology DSD, or the oncology protocol, that did not necessarily apply today to the DSD patients. However, almost all of them we've had conversations about cancer. And so having a protocol where that word is used a lot, but having that not be necessarily as relevant right now is really confusing. And then the OTC and TTC protocols had binary gender and sex-specific language. So they assumed that if you had sperm, that you identified as a male, and if you had eggs, that you identified as a female. We now know that there are so many different permutations, both with our DSG and trans kids, that just doesn't make a lot of sense for a lot of people. And so we were able to be inclusive in our language in our updated protocol for DSD, but also we updated our oncology protocol to be more inclusive because trans kids get cancer too. So we were able to make some improvements to our oncology protocol through what we learned from developing this one. So I thought, I'm like a table person. The people in the back that know me well know that I think in tables. And so I tried to make a table to break down in my mind what the differences were and why it was so important to adapt and adjust our protocol for our patient population. So Again, there's a separate, for the oncology protocol, there's separate protocols for ovarian and testicular tissue. That makes perfect sense. The processing is different, as we talked about. A lot of what's known about the science is different, et cetera. But for DSD, again, not totally relevant. And so for our patient population, the ovarian and testicular tissue is within the same DSD, within the same IRB protocol. And the implication of that is just that there's a possibility that we don't know what type of tissue we're going to find when we go to the OR, or that some patients have both ovarian and testicular tissue. And thinking about the condition, again, for the TTC and OTC protocols, it's a cancer population, oncology population, or some other condition requiring like a stem cell transplant versus our DSD patient population. Occasionally they meet, but usually they're separate. And like I mentioned, the cancer language is often not directly relevant and can be really scary for our patients. And it's hard when there's like a 15-page consent document to say, well, this part doesn't really apply to you, but it has to be in here because this is the protocol that we have. And then the oncology protocol, again, assumes that the tissue type matches their gender identity. The DSD protocol makes no assumptions about whether your tissue type will match what we were traditionally taught about gender and sex. And so our DSD protocol has inclusion of a range of gender identity and tissue types that are seen within DSD populations. So here's the lessons learned. And again, this is distilling like a year of work into a slide. We learned that it is critical that both the DSD teams and the fertility preservation teams are closely involved in the protocol editing. I'm part of both teams, but I tend to live more in the DSD world most of the time. And at times, one team or the other team was more involved and edited. And I think had we both sat down at the beginning and wrote an outline together, that would have been better. And I think rather than sending it back and forth and having each sort of sub part of the team adding in their piece. So that's one sort of recommendation. Ultimately, we ended up submitting and resubmitting, and there was a lot of sort of ethical concerns and just misunderstandings about what DSD is and how that's different from transgender and all of that. And ultimately, we just had to go in person and talk to the people in the IRB. The IRB is a huge range of specialists and also community members, and so people are coming from very different backgrounds, and sending something in Word with comments and changes is nothing compared to being there in person. And that sounds silly and obvious, but it took us, I think, a few months of going back and forth to realize that we just needed to go and have a meeting where we talked about our patients personally. For at least this first iteration of the protocol, it was really critical that the IRB understood that the gonadectomy surgery was otherwise clinically indicated and desired by the patient and family. So a lot of the concerns that the IRB had and that people had about this was that we were so excited about fertility preservation that we were sort of maybe unintentionally going to be pushing families towards having gonadectomy that they otherwise didn't want for the possibility of preserving their tissue. That is not true. And so again, that conversation in person to help the IRB understand that this is one part of a very complicated set of issues that we discussed with these families, and that we were excited to be able to offer fertility preservation, or preservation of fertility potential for individuals who wanted the surgery, but that we didn't have an agenda. For some families, not preserving the tissue is the right decision for them, and we get that. So I think, again, that conversation about those nuances was really critical. And there was a lot of back and forth about whether we should exclude or include individuals with 45X Turner syndrome or other mosaic Turner syndrome patients who do not have Y chromosome material. Technically, if you look back to that 2006 consensus statement where DSDs were defined, Turner syndrome without Y technically does qualify as a DSD. But there are a lot of different issues with that patient population. Their risk of gonadal malignancy in general is not thought to be higher. And so ultimately, we ended up not including that population in this iteration of the protocol, and that will be a separate protocol we're working on developing now. So again, I'll stop there. I didn't print out the entire 230 pages, but I printed out the 30 pages that I thought were relevant to this group. And I'm happy to talk to people more, but we have a few copies if you're thinking about starting a protocol like this at your institution and curious what we ended up writing after all this back and forth.
So we can take a brief break here again if you have any questions now, and then after that I'm going to go through a few cases. So if you want to wait till we've done that, that's fine, but we thought we'd open it up about this specific portion.
Teresa was whispering in my ear here about the Turner IRB. I guess our Turner IRB is not separate, and we did kind of lump it in, but I don't think we have this degree. We don't have a program like yours. It's dealing with, disorders of sexual differentiation, and I don't think we've gotten to that level at Children's Hospital teasing this area out as much as we probably should. But I do see a lot of Turner patients who come for consultation, and it's kind of wrapped into the protocol. Can you speak to that?
So I think our IRB has been very concerned about fertility preservation being done in a typical Turner syndrome patient. Their concerns have been that this is an unnecessary surgery that they would not otherwise be having, that they may have some spontaneous gonadal function and potential fertility that you are then removing by removing the gonadal tissue. That particularly that the best chance of having viable germ cells is probably if you remove tissue earlier rather than later. But then what somebody has brought up some concerns about making some of these decisions in infancy. I'll just kind of leave it at that. But that has been...
Right. And a lot of times I try to push these patients to freeze their eggs in early adolescence, because then potentially you can do PGD later. And you can see so I think
that would certainly qualify in other... when they're an adolescent and they can participate in some of that, that has definitely been done. But in terms of doing actually the tissue cryopreservation, this is the discussion that we have had. And I think these are really important discussions to have. I don't discount any of those concerns that have been raised at all.
And I think that we have very little information about Mosaic. Okay, so Mosaic, Turner, they're probably going to they have a higher chance of fertility. What's the cut point? Less than so much, over so much.
Right.
We really have no
so
information.
To whom do you offer it, to whom you don't? Right. And then do you take out one gonad and not the other in order to try to split the difference?
Ultimately, we ended up deciding through many discussions that beginning with a patient population where gonadectomy was very clearly clinically indicated for malignancy risk purposes was a good place to start. And then thinking about whether expanding the protocol to include patients who maybe don't desire gonadectomy but who would want a biopsy, for example, or those who aren't thought to have an elevated risk of malignancy but are making an informed decision about gonadectomy, either unilateral or bilateral, sort of weighing the knowns and unknowns and all of that. But we felt, I think, together that a starting point where the decision about gonadectomy was able to be cognitively separated from the decision about fertility was where everyone was comfortable. And honestly, for us, that's the majority of our patient population, but we would love to be able to offer something to the Turner girls that don't have Y chromosome material.
Right, and it's just the tip of the iceberg, because again, there's a lot of other conditions that are associated with POI, and where do we go? Yeah.
Can you just comment on cost and how that if that had any effect on your IRB? Because I know for our oncology protocols, that's always kind of a big stickler, but it seems like maybe it might not be as big of a problem because a lot of these are standard of care. So it might just be your processing fees that kind of... So
essentially the only fee that is seen by the family is the storage costs and the processing, which is the processing is a one-time fee, and then the storage costs is a yearly recurring fee. We do have a sliding scale that we've worked out so that the lowest is $75 a year, which for some families is still a lot, but relatively attainable by most. So in our patient population, that has not been the primary issue, I would say, although we are definitely sensitive to it. In our oncology population, that certainly does come up more commonly.
And then do you have any families who go through the procedure and then opt to not store their tissue once you kind of see what type of gonads you are processing?
Yeah, we have, and I'll explain that one in one specific case in a few minutes.
Okay.
I have a general question about fertility preservation in these very young pediatric populations, and thinking about what is the egg quality in these pediatric patients. Again, thinking about the fact that these eggs at this age wouldn't give rise to physiologic fertility. So are there advances in our understanding of that or research in that direction?
There are some, but I wouldn't be the best person to answer that. I don't know if there's anybody who'd like to take that question as I look on the corner
from
of the room.
a clinical angle.
Yeah, would you like to join our panel?
Here, take this one.
We have sections in our lab that were generously donated to research from some of the patients that Courtney and Emilie see. And we're looking at signs of potential initiation of meiosis, or like where specifically, I think you're interested in the oocytes. So specifically where they are as far as health, like what type of granulosa cells and stuff are surrounding them. So we're going to continue to do that type of research, and we can talk later.
Yeah, I'm just more wondering about the field in general, like what the field thinks in terms of, clinically doing this. Obviously you want to preserve fertility for these individuals, but again, this seems like a very unique population.
And so some of their early research did show, like was one of the first ones to say that there actually is germ cells in the tissue that we think
that there are germ cells and that they decline over time. And so that your best chance of preserving some germ cells may be if you remove this tissue at a young age versus waiting till the patient is an adolescent.
I guess what I'm saying is I think we probably need research in animal models from the basic science side to really understand what is the potential of these gametes, because they're there. But again, a 5-year-old isn't going to be cycling. These aren't going to be producing a mature egg. And so, obviously you'll potentially transplant those or use experimental methods later on. But are those eggs, just because they're eggs and they're there, they could be very, very different. So
we don't know. And are you specifically talking about DSD, or are you just talking about pediatric patients in general?
So I'm talking about pediatrics in general with DSD. That could be a really interesting subpopulation.
Right. Yeah. I would agree. Go ahead. Sorry.
Yeah, I was just going to say, I think this might be a really good opportunity to bridge the basic science and the clinical early on in the discussion.
I would say that goes even to the stimulations that Clarissa mentioned, where she's stimulating adolescent turners. So in the original Oncofertility, any supernumerary or oocytes that fell out, those were ones that went to Francesca for analysis. And that was 20% of the eggs. The 80% then were cryopreserved. And so it really does represent a real opportunity to continue with that split if the IRBs permit that.
Yes, I should comment. I'm sorry, I did not present that nuance of our IRB, but so the protocol in the operating room is that the tissue, so you do the gonadectomy, have the tissue on the back table, divide the tissue longitudinally. Half goes for pathology, half goes for temporary storage, and a little bit of the half goes for research. Once the pathology is available, then a final decision is made about cryopreservation, and that decision is based on presence or absence of germ cells and presence or absence of any malignant cells. So if there's malignancy, the tissue is recalled from the lab, and the rest are from storage and from the experimental lab, and then sent to pathology, so the remainder of the gonad can be examined. I apparently get cut off after 20 seconds, but so there sort of is a process in place for temporary storage, and then a final decision about, I don't know if that one works, about, can you hear me on this one? A final decision about cryopreservation based on the biopsy, and we'll go more into detail about the family that decided not to preserve later.
Oh, Lena, go.
Just one other comment. As we're talking about the nuances of these specific populations, it goes beyond just the fertility potential too, because with Turner's, we have to think about the future risk of pregnancy, both to the mother and to the increased risk of miscarriage, chromosomal anomalies. So I think all of that really needs to be folded into that initial counseling. And it's a similar thought process with Klinefelter syndrome, because as we're having some of these fertility-related conversations, we know that there's a big spectrum of neurodevelopmental issues in that population. So, somebody, as I was presenting on Klinefelter's infertility at a large conference, somebody said, it's not enough to just have fertility, you have to be a father later too, right? So sometimes I think those of us working in pediatrics, it just makes it even more challenging, because we don't always know all of those future considerations, but it's just something to think about.
Yeah, I think that when I see Turner patients, we talk about all those issues. We talk about the fertility. We talk about the fact that, what's the cardiac status? Are they going to be safe to carry a pregnancy? There are a lot of programs that will never do a transfer in a patient with Turner syndrome, even if they have a completely normal cardiac evaluation, et cetera. We have, and we've been, knock on wood, the Turner patients that we've had and gotten pregnant have been thoroughly cleared and done fine during pregnancy. But of course, that's a huge concern, and I think that many will pursue carrier cycles. So.
All right, so now after all of that theoretical discussion, we'll talk about the patients a couple of the examples of some of the patients in whom we have gone through this procedure. So the first one is an 11-year-old girl who ultimately was diagnosed with mixed gonadal dysgenesis, but she had a rather unusual presentation. So, and I'll explain what I mean by mixed gonadal dysgenesis to those of you who may not remember or may not be familiar with this. But first, I'll just say, when this child was born, she had no atypical genitalia at birth, and she did actually see a pediatric urologist for a separate concern, and so she had actually a very good exam when she was a young child. She was diagnosed with short stature at 4 years old, though, and a karyotype was done, which showed a 45X, 46XY karyotype, and she was diagnosed with Turner syndrome at that age. So she was treated with growth hormone, and she was monitored as we typically would for a girl with Turner syndrome. But at 11 years old, she demonstrated some virilization. So she developed clitoromegaly, and she developed some rugation of the labial tissue. And so this is certainly not what you would expect in a girl who has typical Turner syndrome. And so this prompted evaluation within our program. And ultimately, she was diagnosed with mixed gonadal dysgenesis, which can have the same karyotype as Turner syndrome, where you have this mosaic karyotype with Y chromosome material. But in mixed gonadal dysgenesis, on one side you typically have a streak gonad, and on the other side a dysgenetic testicle. And the streak gonad doesn't produce any anti-Müllerian hormone, and it doesn't produce sex steroids. So on that side, you have a partial Müllerian and uterine structure. On the other side, you would expect to see a dysgenetic testicle, and that will produce some AMH, so you'll have regression of some of the Müllerian structures on that side, and then you'll have variable testosterone production, which will lead to a variable degree of virilization of the external genitalia, and then a variable amount of testosterone production during puberty. So in this patient, when she presented, she had pubertal gonadotropin levels, and she had a significantly elevated testosterone level. Now, because for the pediatric endocrinologists out there, and for you'd say, well, are you sure she didn't have a androgen-producing tumor? And we are sure, but that did come up at the time. That was a consideration that maybe this wasn't from a dysgenetic testicle, but I can assure you that this is the diagnosis now. So. This patient is one in whom we discussed the option of gonadectomy and ultimately fertility preservation. So she had pubertal onset with undesired masculinization. And so one of the options at that point is to consider just using pubertal suppression, just using a GnRH agonist to suppress puberty. She's 11, and to allow her to get a little bit older and then make some of these decisions about whether she wants to remove gonadal tissue or not. We also discussed the increased risk of gonadal malignancy in these situations in anybody that has Y chromosome material with abnormal gonadal tissue. And so we had a lot of discussion around that. Ultimately, the family felt that this, and the child met with our psychologist in our program and had a long-standing and very clear female gender identity. So a lot of that discussion happened around sort of just the management of undesired hormone exposure during puberty and all of the virilization that she was experiencing. Then there was also discussion about her parenting desires for the future. And she was this sweet little girl who had always wanted to be a mother, had talked about it since she was a little kid, had told her parents she wanted to be a teacher so she would have her summers off and she could be home with her kids, and she wanted to have a minivan full of children. And so when they had originally gotten this diagnosis of Turner syndrome when she was 4 years old, this was really devastating to them because this is how this child had talked throughout and continued to throughout her childhood. So fertility was a big deal for this family, and for even as young as 11, she was a child that was expressing this as very important to her. So there was a lot of patient and family counseling about the option for fertility preservation at the time of gonadectomy, and discussing certainly the experimental nature of the procedure, and then that the patient has a female gender identity, but that when we would be preserving tissue, we would expect that the streak gonad would not have any cells that would be worthwhile for preservation, but that the cells that might be valuable for potential biologic fertility would be in the dysgenetic testicle. And in that case, they would likely be spermatogonia, or with some sort of sperm precursor. So we had a lot of discussion about this, and the family decided to go ahead with gonadectomy and to at least take a look at the dysgenetic testicle and consider fertility preservation. So in fact, she had a left streak gonad with no germ cells and a right dysgenetic testicle with spermatogonia and no evidence of spermatogenesis. The family ultimately elected not to preserve that testicular tissue. For them, the idea of preserving testicular tissue and spermatogonia for their child who identified as female was it didn't fit for them. And so they had time after the surgery to make this decision. So they don't have to make a decision that day. As Emilie explained, the tissue is kind of saved. It's like a temporary storage. And then we can give them the results, and they can think about what they wanted to do, and they elected not to preserve the tissue. But they did say after that decision that it was a hard decision to make, but they were really glad that they had the option to make it. Like, it just made them feel like they had done everything, they had the chance of whatever options were out there. So that's one of our first cases. The next one is also an 11-year-old girl, but this patient has partial androgen insensitivity syndrome. So this child was diagnosed with this at 6 months of age. When she was born, she was noted to have some around 6 months of age, actually. At birth, nobody really commented on her physical exam, but shortly thereafter, she was noted to have some clitoromegaly, some labioscrotal fusion, and a palpable right gonad. So in partial androgen insensitivity, an individual has 46 XY chromosomes. They have testicles. The testicles make AMH as they normally would, so you have regression of Müllerian structures and no uterus. And they produce testosterone, but there's a mutation in the androgen receptor. And so they sort of don't see all the testosterone. They don't respond to all of the testosterone that's there. And so this leads to a partial androgen effect in the external virilization, and then ultimately in how much they can respond to testosterone in puberty. So some individuals with partial AIS are raised as male, some are raised as female, some identify as male, some identify as female. This is one of the more complicated conditions that we take care of in this field, because in terms of discussions with family about future the child's gender identity, how their genitalia may develop during puberty, all of these things, there are just a lot of unknowns. And then their tumor risk in the gonads is relatively high. Depends on whether the gonads are descended or not. But it just adds a lot of complication to a lot of the discussions that we have with these families. So this child was diagnosed early at about 6 months of age. She was raised as a girl, and she had been referred to us from a different state, but she had had really great care over the years. There had been a lot of discussion with the family about germ cell cancer risk, the option for gonadectomy, and the family actually inquired when the child was really, really young, like even as much as 6 months or a year. They were asking, well, if we do a gonadectomy, is there any kind of way to preserve that tissue? And when she was little, that really wasn't on the radar much. And so the family actually decided not to pursue gonadectomy when she was an infant or a young child. And so at 11 years old, she still has her gonads, but she started puberty. And so at 11, she began to experience some virilization. She developed some clitoromegaly. She started to notice maybe a little change in her voice, but mostly just really mild clitoromegaly. And this was distressing to her. This was, she had a family that had been very open about her diagnosis throughout her life, so she had always known she had this. They had had a lot of conversations about it, and she expressed, again, a strong female gender identity and distress about the virilization. So she had initially had seen her initial team and talked about, the option of pubertal suppression versus gonadectomy at this point. And they thought about pubertal suppression. Their insurance denied the GnRH agonist, and they had already been denied through one appeal. And in the process, she was experiencing more virilization. And the family said, we've really thought about this. She's been involved in this, and we just want to pursue the gonadectomy now. So, but again, just like they were 11 years ago, they were interested in fertility preservation. And so ultimately, again, the patient and the family were counseled the same things about the experimental nature and that if we preserve gonadal tissue, that we will be preserving testicular tissue likely with spermatogonia. In this patient, she was found to have peripubertal testes with decreased germ cells and Leydig cells, nonspecific degenerative changes, no evidence of tumor, and there was spermatogonia present, and this family elected to preserve the tissue. So they had been kind of expecting to preserve testicular tissue all along, so this wasn't a big surprise for them. They'd known her diagnosis for a long time. So two very, in many ways, similar cases with different choices made by the family. And then we're going to move on to the third and last case that we'd like to present, which is an infant with an ovotesticular DSD. So prenatally, on ultrasound, they had noted that the family had been told she was a girl with swollen labia. And at birth, she was found to have atypical genitalia with a prominent clitorophalic structure, hyperpigmented labioscrotal folds, and no palpable gonads. Her karyotype was 46XX. Endocrine testing showed very elevated testosterone levels, and she had AMH production suggesting that she likely had some testicular tissue, and we suspected an ovotesticular DSD. So this patient underwent laparoscopy, and you'll see here what was found. Number one here, right here, is, or in this image, Emily, you can jump in if you want. We'll let the surgeon talk about the surgical imaging.
Should point out the uterus and everything, because apparently yesterday people were interested in just looking at the anatomy.
Okay,
so
yeah.
That I can do. I did a perfect job.
I do well when they label things for me,
Yes,
but
let's
I'll
see.
let her do it since she's here.
Uterus, tube, yes, prepubertal, and gonad. On this side, you can't see the uterus, but this is the gonad on the right side. So you can imagine if this were to be contiguous, this is the left side uterus and then right side. So if you look at number 1 and number 2, this is sort of a polar appearing gonad. And for this procedure, this was her initial procedure, and we just wanted to do biopsies because we suspected her diagnosis, but we wanted to have more information with a tissue sample. So when we biopsied this area, that came back as well-developed ovarian parenchyma with numerous stages of follicle development. And when we biopsied this area, that came back as dysgenetic testis. So this gonad had both ovarian and testicular tissue in the same gonad. This, you can see, is very clearly demarcated, partially because she was really young, so there was enough sort of maternal hormones around that the ovarian tissue was nice and plump and easier to see. And then when we biopsied the left side, that showed well-developed ovarian parenchyma with follicles, but sort of less prominent than the other side. So this diagnostic laparoscopy with biopsy confirmed the suspected diagnosis of an ovotesticular DSD, where there was ovarian and testicular tissue present in the same patient. It would have been hard to imagine what else this would have been with an XX karyotype, because most of the conditions where testosterone is produced would be either an XY karyotype or some other karyotype with Y chromosome material. So she was a couple months old. Yeah, very young. Yes, because
And the reason for laparoscopy
was that there's multiple reasons for laparoscopy, but ultimately it was to to have a firm pathologic diagnosis for her condition. This was a tough one as far as gender assignment. Karyotype didn't necessarily match hormonal studies, and so having as much information for the family as possible in terms of counseling about prognosis, gender identity, et cetera, was really critical. So that's why she had a laparoscopy at such a young age.
Yeah, I think in patients like this, I should say we don't always proceed to a diagnostic laparoscopy and biopsy this young, but for some of these families, it is they have found it very helpful to have some other concrete information other than a lot of the I don't knows or we think that this is probably what we're dealing with that we can sometimes get into. So with this information, no gonadectomy was performed, nothing else was done. This was just a diagnostic procedure. So then when you think about an infant with an ovotesticular DSD, you have to think that these are some of the considerations we have about gonadal management and fertility preservation. So if you look in the literature, there is not a lot about ovotesticular DSD, but there's some information. There's a risk of germ cell cancer in both the ovarian and the testicular tissue components. The ovaries are typically well developed. They have prepubertal primordial follicles present. Some postpubertal individuals are found with developing follicles, and there is spontaneous fertility reported. As for the testicular tissue, it's almost always dysgenetic, but there are some young patients who have been found to have spermatogonia, and spontaneous fertility with sperm has also been reported in individuals with ovotesticular DSD.
They have female external genitalia? No.
Well, you can see any degree of virilization.
Okay, got it.
Mm-hmm.
This is another. Ovotesticular DSD is another condition where, like PAIS, where there's a huge range of how the genitalia appear, about how the patients identify, what type of germ cells are predominant. All of that is really heterogeneous amongst this group. So I think for this patient, also having both the pictures and the pathology is actually helpful. And just giving as much information as possible to the family. But these are some of the toughest decisions when the diagnosis is made in infancy of sort of advising parents about gender of rearing, that kind of thing. It's really challenging.
And there's one interesting paper that talks about the effect of ongoing androgen exposure to ovarian tissue in an individual with ovotesticular DSD. So Emilie referenced that there's a lot of controversies in the field of DSD about particularly surgical management, if and when to do gonadectomies, and then genitoplasty is a whole different discussion. But when you talk about the if and when to do gonadectomy, many advocates within the DSD or intersex community will argue that just leave the tissue, leave all the tissue there, there's no harm, and then let the individual make decisions when they're older. But I did find actually a really interesting paper out of the University of Chicago that's very recent, in which they actually showed that there was some PCOS-like effect on the ovarian tissue in an infant with an ovotesticular DSD during the time of ongoing testosterone exposure. And so the question of what effect that would have long-term in terms of not just fertility, but metabolic risk and all of these other things, I think is an interesting one and something to keep in mind. But so at any rate, this is all about as clear as mud in terms of what to do in these patients. And so these are really hard discussions, because not only is you have typically, you have parents with this new baby who are stressed, and this is usually an unexpected diagnosis, and you're trying to explain all of this, and we don't know what to predict for any individual. So these are really complicated. With this patient in particular, the family had decided to raise her as a girl, and we discussed the question about gonadectomy with the patient's mother. That really, they're raising her as a girl, but we really don't know what this individual's gender identity is going to be. There is a risk of germ cell tumor. It's probably low right now, but as we discussed earlier, monitoring for gonadal tumor is really difficult. If this patient does not undergo gonadectomy, when she reaches the time of puberty, if this dysgenetic testicular tissue works, and if she still identifies as female, then having masculinization might be undesired. Whereas if she identifies as male, she may be very pleased that this testicular tissue is remaining. We don't know if she desires biological children, and this has been really tricky because the father hasn't been able to attend the visits, and he has a job that sends him all over the country without much for long periods of time, and he doesn't have any control over a lot of this. And so they were really difficult discussions to have. But in addition to talking about gonadectomy, we then also talked about fertility preservation and, of course, the experimental nature, but also then if we're pursuing gonadectomy, are we removing all of the tissue, just the ovarian tissue, just the testicular tissue? What are you going to do? And the gametes may not match gender identity no matter what you've removed. So these are the quandaries that we have, and but this patient just has an update now, so I'm going to let Emilie give the update.
The slides were due before her procedure, but a couple days after the slides were due, this child was taken to the operating room, and I did not do all of the counseling. The dad did come the day of surgery, finally, but that's a hard time to begin to have this discussion, obviously. Prior to that, my colleague, Dr. Yerkes, did a lot of the discussion with the family, and ultimately what the family decided was, if possible, remember the gonad that looked more polar, if possible, that we would just remove testicular tissue if we thought there was a way to really clearly demarcate. And if that didn't seem technically possible, that we would do a gonadectomy on that side. So the child is about a year old now, and ultimately we ended up performing a gonadectomy on that side because the maternal stimulation is not present anymore. That polar appearance that you see there, it was not nearly as well demarcated, and we did not feel that we could reliably separate the ovarian component from the testicular component to achieve the goal. So this family is very, very clear about gender rearing as female, and wanted testicular tissue removed, but wanted that tissue to be saved if we removed it, if in the future the patient did identify as male, essentially, and desired fertility from male gametes. So we have pathology back. I actually don't know if the family ultimately decided to preserve because it's sort of late breaking news, but pathology, I think we did the right thing in doing a full gonadectomy because although you see that demarcation, there was some blurring at the border. And so in the tissue that looked to be mostly ovarian, there was a little bit of sort of dysgenetic testicular tissue creeping in and vice versa. So I think it would have been, even when it looked like that, I think it would have been really hard to make sure that we removed all the testicular tissue. So assuming that they elect to save the tissue, this will be our first case where both tissue types are preserved, and it will be our first case where any ovarian tissue is preserved actually under the DSD protocol. So.
And I think this is where we will open it up for our final few minutes of questions.
Final discussion.
So I have a question. It's so challenging because gender identity does not necessarily indicate sexual preference. Mm-hmm. So I'm sure you asked those questions, but at 11, how reliable is that? You know, because whether to freeze the
right.
sperm, are you going to have a female partner? Are you going to have a male partner? Do you care? What do you? I mean, that's important for reproduction.
It certainly is, and we're very fortunate because the psychologist that is integral in our team and is there for every clinic, every visit with all of these families she also works in our gender program, and so she is very, very good at having some of these discussions with our patients. And at 11, there are some children who do have a very clear sexual orientation and others who don't. And so part of the discussion that we have to have, but that's hard to have with a preteen, but even an older adolescent, is the understanding that they have to understand a lot about about how reproduction really works, and then what assisted reproductive techniques could be used, and how really you just need an egg and a sperm and then a place to put it. But having that discussion is very complicated, and yes, it is really it is a tricky part of our conversations.
Right, 'cause when I see the transgender adolescents, right, I have that conversation. We need a sperm, we need an egg, this is somebody needs to carry it, and so what is do you have any idea what your sexual preference is? Because if we freeze, if you have a female partner, maybe you use her eggs, and then we need sperm, and so.
Right. And understanding that you don't,
really important.
right, but that's part of it.
I think it's part of the discussion, but I would say that especially because the younger people that we see, a lot of them are just much more expansive about their ideas about gender and sex, and they grew up with a much more fluid idea about all of that. And so for some of our families at least, this discussion is much easier than it would have been 20 years ago. Interestingly, when we presented this sort of idea for the first time at the urology meeting, there was a lot of like, whoa, like, wait a minute. And Courtney's like, actually.
There was one of the urologists who was like, but you can't have a girl preserve sperm. And I said, well, actually, I was like, if her partner had an egg, it would be fine. It might work out just perfectly. So.
There's a lot of different ways to build a family, and many of our patients, I think, totally get that, much more than the doctors do a lot of times. It's like, they're like, oh yeah, sure, that makes total sense to me.
Yeah.
Whereas the doctors are like, oh my goodness, I just can't even imagine how that would work. So we've been pleasantly surprised, I think, from a lot of our patients about how they think about these things.
So I think that, you guys alluded to this already, but there's clearly situations where we recommend gonadectomy because of concern for malignancy. But then you've also alluded in some of these cases where parents are requesting gonadectomy because what they think, how they're raising the child, and the children are young, so we don't know what their future gender identity is going to be. So number one, I think, I just want to know how your team is tackling that. But then also, do you feel, or has your IRB given you any pushback to say, does layering on the conversation about fertility preservation potentially affect the family's decision even more of that early gonadectomy?
I think that was a big concern when we initially wrote the protocol and presented this to the IRB. You can't completely disentangle all of these issues. I think that has to be said. However, all of the patients at present that we're having a conversation about gonadectomy, even if something about their gender identity factors in, the baseline knowledge is that their malignancy risk is higher than the general population. And so if there was a situation where the parents were making an assumption about what their future gender identity was going to be, and the patient did not have an increased risk of malignancy, and they were requesting a gonadectomy for that reason alone, which I can't exactly think of a situation. Maybe a relatively young trans kid, actually, like if a parent had requested gonadectomy for that reason, we would say no. But these are not kids where that's the situation. They all have an increased risk of malignancy to a certain extent, and the other issues do factor in, but we sort of have to go into this with that baseline assumption. I think that's why the Turner girls that don't have Y chromosome material, why that's a more difficult conversation, why thinking about adapting this protocol for the trans kids who don't have a known DSD, why that's more difficult, because there is not an increase. The gonads are inherently more normal in those cases, so that's why those situations are even more challenging when it comes to a surgical protocol. For these kids, there's a lot of other issues that are hard to explain to the IRB, but the idea that gonadectomy might be considered or recommended is very clearly the standard of care.
Yeah. And I think there are a couple, and I'll make this the last thing, but there are a couple of these people who had planned, like scheduled gonadectomies at other institutions and have canceled them and come here to do the fertility preservation with the gonadectomy. So we kind of go through all the counseling again beforehand, but that has been, that's already a decision that's been made.
Thank you so much. That was absolutely fantastic. So many questions, and I think you're really paving a new way for these patients. So I think you're doing, thank you for all your hard work.
Thank you.